All right, we're going to be talking about benzos, sedatives, and hypnotics in this lecture. The first drug that we're going to be talking about is etomidate. You'll see a typical packaging of etomidate right there, and 40 milligrams per 20 mLs. We're going to look at your drug cards here in just a minute. Etomidate, one of the things to remember with etomidate, it's usually a single dose. So if you are doing a procedure such as RSI or a conscious sedation, and you need to extend sedation, or if you move on because that procedure was not successful, you usually need to get medical control orders in order to give a second dose. There are some advantages to etomidate. First one, it's very short acting. The typical duration of etomidate is around 5 minutes, depending on the metabolism of the patient. Why that is beneficial to you when you sedate a patient, particularly for rapid sequence induction or intubation, that procedure from start to finish, and when you sedate that patient to placement and securing of the endotracheal tube, should definitely not take more than 5 minutes. And you want that patient to be waking up in case you are struggling with the procedure. You want that patient to regain control of his or her gag reflex, protecting his or her own airway. And when we talk about paralytics, you want the respiratory drive to come back. There is also a minimal effect on blood pressure. So for patients that are kind of borderline, you can give this with relative safety, and it's very fast acting. All right. So as a review, let's go over your drug card, and we're going to talk about etomidate right here. So other name, amidate, you'll see that right here. And let's talk about the mechanism of action, because that's really what the lecture is on right now. You'll see right here, short-acting drug that acts on the level of the reticular activating system to produce anesthesia. Well, what is the reticular activating system? Before we can really discuss that, we're going to talk about GABA and what that neurotransmitter is. The GABA is short for gamma aminobutyric acid, and there are several medications that we give that affect GABA. Now, when GABA is released, you'll see right here that it is a neurotransmitter, so it is in the central nervous system in your brain. And what does it do? It reduces the impulses between neurons in the brain. So if you've got two neurons and they are firing, and going too fast, and we slow them down, what is it going to do? It's going to increase relaxation, it reduces stress, alleviates pain, creates drowsiness, and calmness of mood. All right. Now, remember what we talked about last lecture as far as threshold and the therapeutic effect. All right. So there's a range of therapeutic effect. You can have a low effect, and as you give more medication, you can have a high effect. All right. And so this will make more sense when we talk about benzodiazepines in just a second. But when we talk about GABA, there's two different receptors that we typically talk about. We talk about GABA A and GABA B. All right. What we are targeting is GABA A. This is going to be benzodiazepines, barbiturates, alcohol. What happens when you activate these receptors? So if you have a GABA A receptor, okay, and I activate that receptor with a benzodiazepine, what ends up happening with etomidate, we'll get to that in just a second. But if I activate GABA A, it releases GABA. Excuse me, that should be capitalized. It releases GABA. And what does GABA do? Well, let's look back on that last slide. GABA does all of these different things. So when we talk about sedatives and we talk about medications that will calm somebody down, will sedate somebody. You can see why that happens. GABA B, there is also an analgesic effect when we talk about GABA B receptors, and this is the target for some psychiatric disorders when GABA receptors are targeted based on antipsychotics. Okay. Well, what is the reticular activating system? This is the part of the brain that is responsible for sleep and arousal states. And there's 3 different states with these. Waking, you're asleep, and then you're asleep and dreaming. Not real important that you know that. What's more important is the reticular activating system. You know that it's a part of the brain responsible for sleep and arousal space. Now, very important here. When we activate the reticular activating system, that stimulates your GABA receptors, right? So let's go back to your drug card here and see how this all correlates. It acts on the level of the reticular activating system to produce anesthesia. All right, so if I work on the reticular activating system, I'm stimulating GABA receptors, and I'm also responsible for my sleep cycle, right? So it produces feelings of relaxation, stress, drowsiness, calmness, as well as producing an amnestic effect, which is basically putting the patient to sleep. Now remember some of the benefits of etomidate, okay? Right here, short acting, minimal effect on blood pressure, and it's extremely fast acting, beneficial. And when I teach you RSI and I teach you how that procedure goes, you are going to learn that you want a medication that takes effect pretty quickly, doesn't last a whole long time, and isn't going to make your patient hemodynamically unstable. That's why etomidate is one of probably the top 2 medications that's given for a sedative when we talk about RSI, rapid sequence intubation, or induction. All right, so now what does this mean for you as a paramedic? When you are considering etomidate, what should you be considering? Somebody that you're going to be placing an endotracheal tube in, or maybe a conscious sedation, depending on your protocols, something like a cardioversion where it doesn't take very long and you want that patient to wake up. So look at your indications right here. Sedation for a painful procedure, right? Well, if we put our patient to sleep and they're not aware of what's going on, that's a good thing. Contraindications, there's not many, just hypersensitivity, which is an allergy, remember, and labor and delivery. Dosages, usually this is dosed on the 0.3 to 0.4 milligrams per kilogram, and depending on your protocols, you might have a maximum dose. And the patients that you want to be concerned about, those who are actively vomiting, because this can have a side effect of more nausea and vomiting as well. All right. So let's talk about vitamin K here, which is also ketamine. It's become very mainstream in the last 5 years or so in pre-hospital medicine. There's quite a few different uses for it. Our 2 uses that we're going to talk about right now are going to be sedative and induction agent. But this is a pretty typical packaging, 200 milligrams per 20 mLs and then 10 milligrams per ml. You'll see that right there. And then you'll see that it's a 20 ml vial, so this one's got 200 milligrams. Okay. With ketamine, one of the things that ketamine does is it creates this sense, when it's given at a sedation dose, of profound disassociation and anesthesia. This will be the, lights are on, nobody's home, and it's kind of creepy, almost like out of a horror movie where they're just staring at you blankly, emotionless. All right. Some very, very good benefits to using ketamine. It usually does not have any effect on your BP, no effect on your heart rate, It causes some degree of bronchodilation. So if you're dealing with a patient with bronchodilation issues or bronchoconstriction issues that you might need to RSI, this might be a induction agent of choice. Also, ketamine, I should have this in here, ketamine does not affect your respiratory drive. So some of the other medications like etomidate can actually decrease the respiratory drive and decrease the respiratory rate and tidal volume, which obviously is problematic. Ketamine does not. There is a study out there that says it does raise intracranial pressure, so it may be contraindicated in increased ICP. So maybe if you are RSIing a closed head injury or an isolated head injury or multi-system trauma patient where there are other signs and symptoms of increased intracranial pressure, you might want to consider something else. Now, let's go over here to the pen book and remember, what are your signs of increased intracranial pressure? If you remember, this is referred to as Beck's triad. So you have decrease in heart rate to the point where it's actually bradycardia. You have an increase in blood pressure, and you have irregular respirations. So if you are seeing these things with a patient and you're considering RSIing, you probably want to choose etomidate or some other induction agent and not ketamine, because ketamine could make that actually a little bit worse. All right, so let's review the drug card real quick here. I'm going to just back out and find this quickly for you. All right, I'm going to zoom in here to ketamine, and we're going to talk about the mechanism of action. So you'll see right there, it acts on the limbic system and cortex to block afferent transmission of impulses associated with pain perception, produces short-acting amnesia without muscular relaxation. Let's talk about what actually ketamine affects, and we will talk about the limbic system, the cerebral cortex, and the thalamus. These three things, okay? So I want you to know what all three of these do. All right, so the limbic system of the brain, it regulates emotion, behavior, motivation, formation of memories, and olfaction. Your cerebral cortex, all right, memory, attention, perception, awareness, thought, okay? Big one here, consciousness as well. So your thalamus sends sensory motor signals to the cerebral cortex, regulates consciousness, okay, sleep and alertness. You'll see why ketamine works now, all right? So if it affects these three systems and destimulates or depresses these systems, you can see we're going to get an alteration in consciousness, especially perception, awareness, and thought. All right, I'm going to show you a video here in just a second of somebody who has received low-dose ketamine, because if you'll notice on your drug cards, ketamine can also be used for pain control here. That's typically a much smaller dose, about a 1/10 dose, rather than a full sedation dose or an amnestic dose. All right. Ketamine also acts on NMDA receptors, and that's N-methyl D-aspartate receptor, and it blocks those receptors in your brain. And when it blocks those receptors, what it does is it stops those signals between those three systems that we're just talking about, your thalamus, cerebral cortex, and your limbic systems. And so it produces, what are we looking for? Those three things. All right. All right, so let's show you a video on ketamine Kate here. So the ketamine Kate here, so this is the pain control dose, all right? The pain control dose with ketamine is, like I said before, typically about a 1/10 dose of what you would give for a patient who's going to undergo a painful procedure or an RSI. The the goal is to basically disassociate them, alter their perception of pain, and really what you're doing is you're putting them in what's called the K-hole, the mindset that people abuse ketamine for. They want this state, and this is where people who use ketamine recreationally, they try to get into this state of mind.
Say something. So, what's this world like that you see with compartments?
Are there a lot of people walking by because they're buying things?
No.
Like I'm not on a conveyor belt?
No. You're on a bed.
That's not fabric?
No, that's the ceiling with lights.
Looks like moving fabric.
Really? What color is it?
It's soft.
Oh, the color's soft.
Do I have both feet?
Both feet are just where they need to be.
I feel like there won't be. I think the pain is still there. That's what that is. It's probably the pain. This looks like a window. I can look out the window. This is crazy.
Yeah?
Is there a man with the purple shirt right here?
There's no one there. No one's there.
But I'm getting closer to that window.
There's no window there.
Yeah, there is. It looks like London.
What's on the other side of the window?
It's a light.
Good job. You got it.
Oh my god.
That was weird, wasn't it?
Keep going. This is...
So what were the potatoes? They came and told me that you were talking about potatoes. And the world was made of boxes.
It's falling into it.
What's falling into what?
It's pretty.
This other world?
Whoa. I see why it's clean, because the marshmallows are eating the potato boxes.
Oh.
This is fine.
Yeah, it is. You're gonna be okay.
I have 2 legs.
You 2 legs, 2 beautiful
They
legs.
feel like they're made of toilet paper.
They probably feel like that because you're on pain medication.
One leg feels like it has its gravity, its own gravity.
Yeah, because you have a special splint on to
One
take
leg
away.
is a planet.
Okay. Yeah, I can see that.
But he's not shaped right.
What's the planet's name?
He doesn't have a name. He's in a drawer.
Oh.
But the drawer is down.
Huh?
Whoa. This was like modern art.
Yeah, we were at Tate Modern earlier, remember? What do you think about the noises?
I'm in the upside down.
You are in the upside down. What's it like?
It moves. I have never done hallucinogenic drugs.
I know.
I think I'm doing hallucinogenic drugs.
They
right
gave you
now.
some very, very strong drugs.
I'm so
Okay.
glad I didn't scream. Bro, I don't even know where I am. Why is the whole ceiling made of little... How tall is it?
It's probably about...
Why is this
10
man
feet.
squeezing my arm?
There's no one standing there. There's no one there squeezing
There's
it.
someone squeezing my arm.
Oh, interesting.
It's my arm squeezer.
Arm squeezer. Your personal arm squeezer. What's his name? We should name him.
Fernando.
Fernando. Okay. I like it.
When I said his name, he let me go.
I'm going to turn this off, okay?
No, don't.
So as you can see, ketamine at lower doses can definitely cause an alteration in pain perception. You'll see down here on this description, she does have a broken femur, which is obviously very painful. That was after she got hit by a motorcycle. So the ketamine was doing its job. Higher doses, it produces an amnestic effect. And like I said before, one of the big benefits is it does not affect respiratory drive. All right, so let's move on to benzodiazepines. You'll see right here, they're anti-seizure, and that is one of the main reasons that you're going to be giving an anti-seizure medication or benzodiazepine. This is your first-line treatment for seizures, with the exception of eclamptic seizures. So remember, eclamptic seizures are those patients who are pregnant and seizing due to preeclampsia, or are postpartum by up to about 3 months and are seizing. Those patients are treated with magnesium sulfate. We can give them for post-procedure sedation, and we can also give them, we can also give them for, sorry about that. We can also give them for pre and post-procedure sedation. You'll see that they are pregnancy class D, so they are potentially harmful to the fetus. So that needs to be taken into consideration if your patient is pregnant, and consider a different sedative. All right, so how do benzos work? I'm going to give you a quick little 2-minute neuroscience video, and then we'll come right back.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss benzodiazepines. Benzodiazepines are a class of drugs named for their chemical structure that are commonly used to treat anxiety disorders and sleep-related disorders. They include well-known drugs like Valium, Xanax, and Klonopin. There are dozens of drugs in the benzodiazepine class, but the mechanism by which they all exert their effects is thought to be similar. The sedating and anxiety-reducing effects of benzodiazepines are believed to be attributable to the drug's actions at receptors for the neurotransmitter gamma-aminobutyric acid, or GABA. In particular, benzodiazepines act at a subtype of GABA receptors called the GABA-A receptor. GABA-A receptors that also bind benzodiazepines are sometimes called benzodiazepine receptors. When benzodiazepines bind or attach to the GABA receptor, they bind at a location separate from where GABA itself binds, and exert an influence over GABA binding. This type of action is called an allosteric effect, and in the case of benzodiazepines, it results in increased action at the GABA receptor. There is not complete consensus on exactly how benzodiazepine binding affects activity at the GABA receptor, but there is evidence to suggest that it increases the likelihood that GABA binding will activate the receptor, and/or increases the effect that GABA has when it binds to the receptor. That effect is to open an ion channel and allow the passage of negatively charged chloride ions into the neuron. This influx of negatively charged ions pushes the membrane potential further from zero, or hyperpolarizes it, and makes it less likely the neuron will fire an action potential. This type of neural inhibition is the basis for the effects of benzodiazepines, for by inhibiting the activity of neurons that make up networks involved with anxiety and arousal, the drugs are able to produce calming effects.
All right, so as you will see, benzodiazepines affect, I didn't mean to go back there, but benzodiazepines affect GABA and GABA receptors. So let's go back to what happens when we release GABA and therefore activate a GABA receptor. Increased relaxation, reduces stress, pain alleviation, drowsiness, and calmness of mood. At higher doses of GABA activation, they can cause loss of consciousness and deep sedation as well. Now, when are we going to give benzodiazepines? Like I said, you're going to give benzodiazepines in several different cases. You're going to give pre and post procedure. Examples would be cardioversion, intubation, and post-intubation sedation. These are also given for seizures. And you can also give these, depending on your protocol, for anxiety. And typically this is for panic attacks. And you can also give them, when we get into the pre and post procedure sedation, I'm going to give you another example of CPAP. If your patient is so air hungry and is not tolerating the procedure well, you can consider calming them down a little bit with a benzodiazepine. All right, so let's go over flumazenil. So what is flumazenil? Flumazenil is basically Narcan for benzodiazepines, all right? So it's a competitive benzodiazepine antagonist, and I'll go over the serious potential for life-threatening conditions and why it's more risky. But what it does is it basically competitively binds at the GABA receptor, so it'll kick out anything that's trying to activate that benzo receptor, that GABA receptor. Remember that GABA receptor is going to relax the patient, reduce the transmission of the neuron. So if you've got a seizure-like activity where the neurons are firing and there's an increase of chaotic impulses throughout the brain, that's why we give benzodiazepines, because the GABA receptors and the release of GABA and the binding of those GABA receptors will slow those impulses down and actually help reset them. Now, let's go over here, and I'm going to open up another tab, and we're going to talk about flumazenil. Okay, so indications would be a benzo overdose, okay? What happens in a benzo overdose? Big one, respiratory depression. And the other thing that we're concerned about is inability to protect your airway. Okay, those two things right there are indications for RSI. So if we have the ability to turn this overdose around and not RSI somebody, generally we would think that we need to reverse that. Now, what happens with flumazenil with a patient normally on benzos or with a seizure history? All right, so if somebody is seizing and we need to give a benzo to break the seizure, and that flumazenil is competitively binding against that GABA receptor, it doesn't matter what we give as far as that benzo, it won't work. So you get into this status epilepticus, and it's extremely dangerous. So flumazenil is always contraindicated in a patient with a seizure history. Now, let's go back to the last slide. Okay, you've got this patient who's got respiratory depression and inability to protect their own airway and has a seizure history. What can you do? You can place an ET tube. You can manage the airway with basic or advanced maneuvers. You can handle that patient. The risk is too great, because if this patient were to seize again, you would have no way to stop that seizure, and that patient would go into status seizure. So flumazenil is always, always, always contraindicated whenever there's a seizure history. I would be surprised if anybody in this class actually has flumazenil on their trucks. It's not very common pre-hospital anymore. All right, last one we're going to talk about, haloperidol. It's also called Haldol. It's a common medication. Well, I shouldn't say common. It used to be more common. It's starting to lose mainstream use with schizophrenic patients. Used to be common with the schizophrenic patients because it does have a clinical use. Schizophrenia, it's thought to be an overactive activity of dopamine within the brain. The signs and symptoms include hallucinations, delusions, there's confused thoughts, disorganized speech, trouble concentrating. These patients might also have movement disorders. Now, what does Haldol do? It blocks the dopamine receptors, and so therefore it regulates the mood and behavior. If we give dopamine, or if we give Haldol at a higher dose, it's going to block obviously more dopamine receptors, and it creates this sedative effect. Often combined with lorazepam, and this is when you hear people say 10 and 2. It's often given 10 milligrams of Haldol and 2 milligrams of lorazepam. You can combine them in the same syringe, so you only have to give an IM injection once, and the patient receives an IM injection. And then one of the reasons that we don't use this very often is because it can take 30 to 45 minute IM onset. Now, you've got a patient who is combative, a danger to himself or herself. You want something that's going to work in 30 to 45 minutes? Absolutely not. You want something that's going to work in about 3 to 5 minutes? That's why we use ketamine. All right. So know that Haldol blocks the dopamine receptors, and remember, dopamine acts on mood and behavior, and in higher doses it creates that sedative effect. Not very common. All right, so I'm going to go ahead and wrap that up. Bring any questions that you have to class on this lecture, and I'm going to go ahead and sign off.